So deep hypothermic circulatory arrest was really instrumental in the early stages of, or the early period of pediatric heart surgery. And with the evolution of surgery and cardiopulmonary bypass and the availability of less obstructive cannulas, it's really taken the role from the instrumental role to more exclusively in aortic arch procedures, where it remains a standard of care. So the benefits of circulatory arrest are the reduced metabolic rate and demand, and that it provides a bloodless, unobstructed operating field. So that reduction in metabolic demand provides a safe period of protection to circulatory arrest. So for example, cooled to 18 degrees Celsius, you have a protected period of up to an hour. And then, of course, selective cerebral perfusion, antegrade and retrograde cerebral perfusion is used in conjunction with circulatory arrest to provide additional protection to the brain. So while this is the standard of care, there are significant complications that come with the circulatory arrest. First, the time that is required to cool and rewarm the patient necessitates longer pump runs and surgical time. Second, the drastic change in temperature alters the coagulation cascade and leads to bleeding complications post-operatively. We also see altered vascular permeability. And lastly, the cessation of perfusion to the lower body usually results in some form of kidney injury. And since this is happening in the kidneys, we can assume it's happening and causing other end organ damage as well, possibly affecting the liver, kidneys, intestines. In fact, increased gut permeability, indicative of intestinal malperfusion, has been seen following the Norwood operation. So my pediatric center in Omaha used a dual arterial cannulation technique, eliminating the need for circulatory arrest, yet still providing a bloodless operating field for the surgeon. And they did this for all aortic arch pathologies. So for dual arterial cannulation, both the innominate and the descending aorta are cannulated, providing full perfusion to the upper and lower body throughout the reconstruction. And this center, you can see the graph here depicts the transition the team made from circulatory arrest and selective cerebral perfusion to the dual arterial cannulation. So before 2007, 100% of cases were done with circ arrest and some selective cerebral perfusion. And then from 2007 to 2011, they began a transitional period. And since 2011, they have completely transitioned to dual arterial cannulation and eliminated circulatory arrest. And that's full flow normothermic bypass to the upper and lower body. And this is not an entirely new concept. It was described by Emoto as early as 1999, but it hasn't been widely adopted. And the surgeon there in Omaha attributes this lack of use to a perceived difficulty of cannulating the descending aorta. So I'll do my best to describe that process here shortly. The case I chose to present was a 9-day-old female weighing 4.3 kilos with a BSA of 0.27. She presented with coarctation of the aorta, aortic stenosis, a VSD, ASD, and PDA. So she was scheduled for her aortic arch reconstruction and intracardiac work. And for this dual arterial cannulation approach, we used an 8 French RMI arterial cannula for both the innominate and descending aorta. We used bicaval venous cannulation, 12 and 14 French. However, as always, the strategy for venous cannulation is determined based on the need for intracardiac work. And we used 18-gauge aortic root needle and an LV vent. So for cannulation, a standard sternotomy approach is appropriate. First, the innominate is exposed and directly cannulated. And while they're cannulating the innominate, they would lightly compress the innominate while watching the radial line tracing to make sure the subclavian didn't connect anomalously. Then for descending cannulation, the beating heart is elevated out of the chest and an incision is made into the pericardium starting about 1 centimeter to the right of the phrenic nerve and extending transversely to the IVC. And this pericardial flap is lifted to expose the descending aorta for direct cannulation. And Then venous cannulation is done last so that the cannulas do not impede venous return during the lifting of the heart, which the surgeon also notes has surprisingly little hemodynamic effect when the beating heart is elevated out of the chest. So if you didn't like my drawings, here's more realistically what it looks like with the beating heart retracted out of the chest. The phrenic nerve is visualized through the pericardium, and a transverse incision is made along the dotted line. So it's easy to tell your surgeons, just cut along the dotted line. And then here, the pericardial flap is lifted, and the descending aorta is directly cannulated. So this slide is really important for the successful implementation of this approach. In the early stages, they noticed a couple incidences of pulmonary hemorrhage and pulmonary dysfunction actually leading to ECMO in 2 cases. So the surgeon started snaring the left pulmonary artery to reduce pressures in the left lung and try to reduce some of that traumatic pulmonary hemorrhage. And he also notes that it's critical to be gentle in manipulating the lung during the descending cannulation. And since these 2 points here at the bottom of the screen, since implementing these, the occurrence has ceased. And they also note that there hasn't been any esophageal injury or aortic dissection in this process, which is important to note. So continuing on, bypass is instated with the proximal transverse arch snared and the left subclavian and left carotid arteries snared. And then there's a cross clamp on the descending aorta. And with this, perfusion of the upper and lower body are completely isolated there to continue throughout the reconstruction. And with this, we monitor upper and lower body pressures throughout the entire reconstruction. So usually a right radial and then either femoral, umbilical, or tibial for the lower body. And these are constantly monitored for any significant deviations in pressure, in which case we would let the surgeon know. And since the arterial line is branched up at the field, he would just occlude whichever appropriate arterial line to balance the pressures. So all extracardiac work can be done without arrest. If the procedure isn't requiring intracardiac work, the repair can be completed without arrest up until the most proximal arch reconstruction. So the PDA was immediately ligated and divided, and the distal reconstruction was carried out as proximal as possible to minimize cross-clamp times. And then for the more proximal arch and intracardiac work, cardioplegia is administered. And for this, the innominate is snared down, and the snare on the proximal transverse arch is removed. We gave a del nido dose of 30 mils per kilo for a total of 131 mils. And they also note it's easier if you replace the clamp on the descending aorta with a snare for intracardiac work to allow for the leftward rotation of the heart to do that work. So the VSD and ASD were repaired this way, and the most proximal arch patch was completed. Some highlights for the case: the pump time was just under an hour, cross-clamp time of 26 minutes. We did muff for 9 minutes after termination. And the nadir temperature was 35 degrees Celsius. We minimized cross-clamp times, and estimated blood loss was 100 mils. So the surgeon at this institution has conducted extensive research on this approach. This study looked at 142 of his aortic arch cases, comparing dual arterial cannulation and circ arrest with selective cerebral perfusion. And in the DAC group of 70 patients, they found significantly lower myocardial ischemic time, procedure, and total bypass time, a lower inotropic agent score, reduced third space fluid gain or edema, decreased time on the ventilator, and increased urine output in the first 24 hours. And survival to discharge in this dual arterial group was 97%. In the circulatory arrest and selective cerebral perfusion group of 72 patients, they found a greater loss in glomerular filtration rate indicated by elevated creatinine from baseline, greater incidence of acute kidney injury and failure, and blood product administration. So this data is really interesting to look at. And the benefits that come from dual arterial cannulation are mostly attributed to the ability to maintain normothermia, which preserves the hemostatic and coagulation function along with platelet function and leads to decreased need for blood product administration. And then just the reduced complications that are typically associated with longer pump runs. So this allows for shorter pump runs and cross-clamp times. And then since we're not limited by the protective period of a circ arrest case, there are no time constraints for surgery. This allows an unhurried operation, possibly fewer mistakes, the ability for the surgeon to take on more complex procedures, and allows time for teaching if it's a teaching facility. And this approach is a particularly good option for any patient suspected to be at a higher risk for post-op kidney dysfunction for the obvious reason of uninterrupted perfusion to the lower body. And it's arguably more ideal in the pediatric population. It's said that the access of the descending aorta is typically easier in pediatrics, and there's absence of atheroma. And then it's also particularly beneficial since children are at an increased risk for microvascular injury and bleeding following circ arrest. And this may be due to their immature coagulation systems, and all that's exaggerated by circ arrest. And in fact, one study found that neonates undergoing circ arrest had 50% reduction in coagulation factors and 70% reduction in platelet count following. So it's particularly beneficial for them to maintain normothermia. And unfortunately, this is the only pediatric site I was able to rotate through. And this is all they did, this is all I knew, so it was only through talking with classmates that I realized not many others were doing this. And so I'm hoping to have a conversation with you all if any sites are using a similar approach or if you think this has merit. And here are my references. Most are authored by Dr. James Halle there in Children's Omaha. And thanks so much.